you. And at this point, I'm going to turn to our second panel, which will be moderated by Corrina Moucheraud. The panel is discussing vaccine access, distribution, and misinformation. As I mentioned, Dr. Moucheraud was one of our theme issue advisors, as an associate professor in the Department of Public Health Policy and Management and the co-director of the Global Center for Implementation Science at the New York University School of Global Public Health. I'll turn it over to you for the next panel.
Great. Thanks so much, Alan, and thanks everyone for being here for this panel. I'm going to introduce our esteemed panelists at the beginning so that there are not interruptions between their presentations. As mentioned, this is a panel on vaccine access, distribution, and misinformation, and our speakers are as follows. First, the panel will open with Peter Hotez, professor and dean at the National School of Tropical Medicine at the Baylor College of Medicine and co-director for the Center for Vaccine Development at Texas Children's Hospital. He'll be speaking on global vaccine access demands combating both hesitancy and inequity. Next, Ashley Fox, associate professor in the Department of Public Administration and Policy at the University of Albany, State University of New York, will speak on substantial disparities in COVID-19 vaccine uptake and unmet immunization demand in low and middle income countries. Third, Bernard Black, the Nicholas D. Chabraja professor at Northwestern University, will speak on the COVID-19 vaccine booster rollout, lives saved in Israel versus the United States, and the cost of caution. Fourth, Rory Smith, Research and Investigation Manager at Brown University, will speak on COVID-19 misinformation interventions, a systematic analysis of effectiveness. And finally, David Ridley, Professor of the Practice and Dr. and Mrs. Frank A. Riddick Jr. Research Fellow at Duke University's Fuqua School of Business, will speak on an evaluation of FDA global drug inspections in the COVID-19 era and beyond. I will hand it over to our speakers. We'll do question and answer at the end. Over to you, Dr. Hotez.
Well, thank you so much, and appreciate having the opportunity to speak for 5 to 7 minutes. Just giving a quick overview. The first slide, please. Next one after that. So I'm an MD PhD vaccine scientist. Did my MD PhD at Rockefeller and Cornell 40 years ago, where I started working on a human hookworm vaccine that's now in phase 2 clinical trials, which is actually looking really promising. That's oftentimes the time frame for vaccines. And then we turned our attention to COVID and made 2 low-cost COVID technologies. The point is, 40 years ago, that was the plan, to be a vaccine scientist, pediatric vaccine scientist, making vaccines. The unplanned part was having 4 adult kids, including Rachel has autism and intellectual disabilities. And I wrote the book, Vaccines Did Not Cause Rachel's Autism, which wound up making me public enemy number 1 or 2 with anti-vaccine groups. But it gave me a front row seat to watch how this movement evolved. So unfortunately, I became not only an expert in the vaccine science, but also the anti-science. And that's what I'll talk about now. Next slide, please. So our vaccine center at the Texas Medical Center, Texas Children's Hospital and Baylor College of Medicine, is co-headed by myself and my science partner for the last 20 plus years. And I like to say we make the vaccines that the big pharma companies would not ordinarily be interested in making, because they're for poverty-related neglected tropical diseases such as schistosomiasis and hookworm and Chagas disease and leishmaniasis. And then around 12 years ago, we started developing coronavirus vaccines for SARS and MERS, severe acute respiratory syndrome, Middle Eastern respiratory syndrome, because at that time there wasn't much interest in those vaccines. So we took them on because they were orphan like parasitic disease vaccines were. And then we were able to pivot our program when the COVID-19 sequence came online in January of 2020. Next slide. And we do a lot of cutting edge technologies like mRNA and particle vaccines, but we also do this. We partner with vaccine producers that belong to what they call the Developing Country Vaccine Manufacturers Network. There's about 40 of them in Asia, Africa, and Latin America, and they all make their own recombinant protein hepatitis B vaccines, or many of them do, which is an older technology, microbial fermentation and yeast. It's very low cost. It's accepted by parents who have been giving recombinant hepatitis vaccine for decades, and simple refrigeration. great safety profile. So it checks a lot of boxes for global health vaccines, and that's what we've been doing for our parasitic disease vaccines, and that's what we did successfully for our coronavirus vaccines, including COVID. Next slide. And so this was the problem that we faced in 2021. I was getting frantic phone calls from ministers of health and ministers of science in low and middle income countries where you ever see the big bubbles there. This is a bubble map of the unvaccinated world on the African continent, South Asia, India, Southeast Asia, Indonesia. And the problem that I see, it was a science policy failure, that there was so much emphasis on speed and innovation, meaning mRNA vaccines, particle vaccines, adenovirus vectored vaccines. And we got some really interesting vaccines. But the problem is, any engineer will tell you, when you go from 0 to 15 billion doses, there was a learning curve. And so what happened was predicted and predictable. Enough doses were made to get bought up by North American countries, US and Canada and Western Europe and Japan. And that really left the African continent, India and South Asia and Southeast Asia out in the cold. And the world paid a price for that, because Delta arose out of an unvaccinated population out of India and affected us, and as well as Omicron out of undervaccinated populations in Africa. Next slide. So we worked with several ministers of health and science globally and licensed our technology for recombinant protein COVID vaccine to India, Indonesia, Bangladesh, countries in Southern Africa, and India went the furthest. Their big vaccine producer in Hyderabad Biological E scaled it up and produced our technology. It's known as Corbevax, and the 75 million adolescent kids doses went into adolescent kids, another 12 million adult boosters, and similarly in Indonesia, which made a halal version known as Indavac, and over 100 million doses got administered. So it provided proof of concept that you don't have to be a big pharma company to still do big things in the vaccine space. Not to demonize the pharma companies, but a key point of the paper is we need alternative pathways, and so that we're not totally reliant on big pharma companies. And I think through our product development partnership at Texas Children's Hospital and Baylor, working with developing country vaccine manufacturers, network members, we think that showed it was possible. Next slide. Now, the world is starting to look at what happens as over the next decade, and this is where we switch gears to combating the anti-vaccine activism. Because of the social disruptions, because of COVID, as well as some of the diversion of resources, there have been now big gaps in our steady progress to vaccinate the world's children over the last 2 decades. So the World Health Organization has now put up this Immunization Agenda 2030, which they call the big catch-up. Next slide. And it's starting out pretty rough, that we've had some reversals in our ability to vaccinate the world's children because of those social disruptions and diversion of resources. But something else is happening, as I like to say. That's me in the monk painting over there, that we've had this superimposed on top of that is this new rise in global anti-vaccine activism that's preventing us from getting to baseline. So I just want to finish the couple of slides showing how I think that anti-vaccine movement has evolved or devolved. Next slide, please. And so it started as version 1.0 with false claims that vaccines cause autism. And that started in the late 1990s. That thread's still with us. But then about 7-8 years ago, it became more of a political movement around health freedom, to talk about that. And then finally, the globalization, the empire. Next slide, please. So even within version 1.0 of vaccines causing autism, there's a lot of shifts in that. The original assertion that came out of a paper in The Lancet in 1998, that turned out to be false. It was a study in 12 kids, falsely claimed that measles, mumps, rubella vaccine, the MMR vaccine, live virus vaccine replicated in the gut of kids to cause pervasive developmental disorder or linked to it. That was shown not to be the case through large cohort studies. But then anti-vaccine groups began monetizing the internet, selling phony autism cures, nutritional supplements, and anti-vaccine books on Amazon. So they kept on switching up what their actual assertion was. Then it was thimerosal preservative that used to be in vaccines, or spacing in vaccines, or alum in vaccines. So you got into this battle of whack-a-mole, or always moving the goalposts. And they said it was HPV vaccine that was causing infertility or autoimmunity. And if that sounds familiar for COVID-19 vaccines, that's where they got it from. They copy-pasted the false assertion from HPV onto COVID-19. Next slide. And that's how I got involved, because of having my daughter Rachel and writing the book, which did a deep dive showing the evidence there was no link, and also what autism is, how it begins in early fetal brain development through the action of autism genes. So that we were able to provide a narrative. We did whole exome genomic sequencing on Rachel, and my wife Ann and I to find Rachel's autism gene. The point is there was a sound alternative explanation. So that did take some of the wind out of sails of anti-vaccine groups, but they came up with something else. And like so many movements in the US, it started in California, but amplified in Texas. So by the 2010s, so many kids were not getting vaccinated that there was a breakthrough measles epidemic. The California legislature said this is not a good idea to allow vaccine exemptions. They shut it down. I agreed with it. It solved the autism problem. But then there was a counter reaction around this concept of medical freedom. And that's what it took off in Texas. Next slide. And in Texas, unfortunately, this translated into COVID, where almost that green arrow shows when vaccines became widely available during the Delta BA1 wave. Almost as many Texans died after vaccines became available as before, because so many Texans refused a COVID vaccine. 40,000 Texans needlessly perished. 200,000 Americans needlessly died. And this is in the paper, because they refused a COVID vaccine. And then the next slide. And ultimately, they were victims of politics. This is from Charles Gaba, the health analyst. Looking at that Delta wave on the right, almost all in red states, and the redder the county, the lower the immunization rate, higher the death rate, so much so that David Leonhardt, the New York Times, calls it a red COVID. So how we talk about that is really tough. This started at the CPAC Conference of Conservatives in July of 2021. First, they'll vaccinate you, then they'll take away your guns and your Bibles. And as ridiculous as that sounds to us, people in my state of Texas accepted that. And then members of the House Freedom Caucus used very aggressive anti-vaccine rhetoric. Senator Rand Paul, Senator Ron Johnson, amplified every night on Fox News. And this was documented by two groups, Media Matters, as well as a research group out of Switzerland. Next slide. So I'll finish to say that, and we can maybe talk about more of this in the discussion. The point is an organized, predatory, well-financed movement linked to party politics in the United States. And unfortunately, that US-style anti-vaccine activism is now globalizing. We're starting to see that same US-style anti-vaccine rhetoric, not only in Canada and Western Europe, but also in low and middle income countries, on the African continent, in Asia and Latin America. So this is now a globalizing phenomenon, version 3.0, and this is the new book I've written to go along with it, The Deadly Rise of Anti-Science, which goes into a deep dive explaining how all this came about. So thank you so much for the opportunity, and I look forward to talking more at the panel. Thank you. And now turn it over to Ashley Fox.
Great. Thank you so much. And thank you for having me here today. That was a really helpful setup that Dr. Hotez gave for our topic, which is on substantial disparities in COVID-19 vaccine uptake and unmet immunization demand in low and middle income countries. So I think what makes our study a little bit unique is that, unlike many studies that have examined vaccine hesitancy or willingness to vaccinate, our study is one of the few that have looked at actual vaccine uptake at least 1 year after vaccines became widely available for public consumption across all population age groups in low and middle income countries. So what our study tries to do is to examine vaccine uptake across 17 Western Pacific and African countries through nationally representative surveys. And the primary goal of our study was really to tease apart these kind of two separate phenomena, but basically the extent to which inequities in vaccine supply have resulted in lower than desired uptake, so what we're calling unmet demand, and how much of low uptake has to do with population hesitancy or low demand for vaccines. So as shown in this slide, basically what we found was that actually many Western Pacific countries achieved near universal vaccination, with greater than 90% of the population receiving at least one dose. and large majorities receiving 2 or more doses. But by contrast, in sub-Saharan Africa, only about 50% of the population in the countries that we surveyed had been vaccinated on average, and only 20% had received boosters. Primary vaccination rates were less than 50% in 4 African countries that we looked at. And across all countries, only 22% of the sample had received the more efficacious mRNA vaccines that were quite widely available in high-income countries. Next slide, please. So when examining this phenomenon of unmet demand for vaccines, in other words, how many people wanted to be vaccinated but weren't, interestingly, what we found was a pretty even split. About 14% of our sample was unvaccinated but not willing to vaccinate, and another 14% were unvaccinated but reported being willing to get vaccinated. And if we look at that just among the unvaccinated, that amounted to about 50% of people that were still unvaccinated because they didn't want to be, so the vaccine hesitant population, and another 50% who wanted to be vaccinated but were not. So these are the people who we are saying had unmet demand for COVID-19 vaccines. So about half of the sample had unmet demand, according to our study. Next slide, please. So unmet demand was also quite variable across countries. A number of African countries had very high unmet demand, between 30 to 40% of the public. And in Western Pacific countries, because there was such high vaccine uptake, there was less variation to look at. But even there, it was a pretty even split among the remaining unvaccinated. Next slide, please. So we also looked at predictors of unmet demand in the countries for which there was this adequate sample to look at this. And what we found was that younger people, less educated people, and to a certain extent, women had higher unmet demand than others in the sample. In some ways, that was fairly unsurprising. We know that younger people were not prioritized. Less educated people might have a harder time getting access to vaccines. The fact that we found that women had higher unmet demand was a little surprising, because other studies have found that women have higher hesitancy in regards to COVID-19 vaccines. And also, surprisingly, we found that living in a rural area was not consistently associated with having greater unmet demand in the way that we thought it might be, but it was in certain countries that had high population living in rural areas. Next slide. So we also looked at, among the hesitant unvaccinated population, what were the contributors to hesitancy, and the 3 largest self-reported reasons for not being willing to vaccinate included, first, low risk perception from COVID-19, second, concern about adverse effects of vaccines, and third, perceived ineffectiveness of the vaccines. So in other words, complacency and low confidence in the available vaccines. So these were pretty standard reasons that other studies have also found support for. Next slide. So in summary, our main findings are that, especially in sub-Saharan African countries, there is substantial unmet demand for vaccines. And we think that this suggests that there are a variety of failures of delivery that are separate from hesitancy, that are preventing people from getting vaccinated. And so addressing some of those supply chain issues and figuring out how to make vaccines available and affordable for people based on need for vaccines is a future priority area. Thank you so much for your time, and I look forward to the discussion. And I think I'm passing it next to Bernard Black, Bernard Black. Thank you.
All right. So thank you. So this project was an effort to say, let's use Israel as a comparison for the US. Israel had an early, very effective booster rollout. The US had a slower, much less effective booster rollout, and try to use a mix of modeling and data to answer the question, how many more lives could we have saved in the US if we moved faster? And conversely, how many did we save by moving when we did, compared to moving even slower? Next slide. Okay, so this is joint work with co-authors, colleagues in Israel, Lital Kanan-Boker, Aharon Glatten-Friedman, Amnon Reichman, and colleagues in the US as well. And so what did we learn in 2021? The mRNA vaccines, which are the dominant ones used in the US and some other countries, were great. They were developed fast. They were highly effective. They were highly safe. But we learned fairly soon that the effectiveness of the vaccines waned pretty quickly within about 4 or 5 or 6 months. I'm going to suggest a better measure than VE when you're talking about serious disease is how much risk is left, which was remaining risk. And so what we learned was remaining risk rose, not only against infection, but also against severe disease. That should not have been a surprise, even though we acted as if it was, based on what we know about experience with other vaccines. So Israel was the first country to experience waning because they were the first to vaccinate most of their population using exclusively Pfizer. And so starting in June 2021, which is only not even 6 months after their first campaign, they had a new wave, exponentially rising infections, hospitalizations, deaths, and most of the hospitalizations and deaths were among the already vaccinated, almost all age 60 plus. They had to do something. They gambled with no evidence on a booster rollout instead of a lockdown. All they really knew was the booster was going to boost antibody levels. How it was going to affect disease rates, they didn't know. The gamble worked. The infection wave receded, and the third dose safety was excellent as expected. Next slide. That was a laboratory. Israel was a laboratory for the rest of the world. We were watching. We could have moved soon after they did. And other countries did move soon after, but the US dithered. Israel rolled out vaccines late July. Anthony Fauci said 4 days later, we're watching, they're getting really good results. We ought to do something. We had a broader public consensus among senior administrators 2 weeks later, and yet we didn't move until 2 months later. And even then, it was only partial. We approved boosters for age 65 plus for the most part, and there was really muddled public messaging about vaccines are still really good. They still protect you against severe disease. We only got full approval 2 months later in late November with Omicron on the horizon. Next slide. Okay, so this slide, the top left lines show for different age ranges. And I'm sorry that stuff got cut off on the slide. These are percentage vaccinated, okay? The x-axis is missing, the y-axis is missing. Israel is on the left. The US is on the right for different age ranges. The question we asked was, suppose you could move the US vaccination booster rate. This is for people who already got the initial vaccine, so they're not the vaccine refusers, toward Israel. How many more lives would we have saved in hindsight? Conversely, if we never did boosters, if you took the US lines, the lower right 3 lines, and just flattened them to 0, how many more people would have died? This is a combination of a modeling effort using the surprisingly poor US data and using the data that we've got. Our answer for moving at Israel's speed and their uptake rate was we could have saved 29,000 lives in ages 55 plus over the next year. Conversely, if we never authorized boosters, we would have had 41,000 additional deaths among the already vaccinated. For comparison, we had about 100,000 deaths among vaccinated over this period. We could have brought that down to 70, or it could have been worse at 140. Why? Next slide. Okay, so next slide. And one more. Okay, 3-letter answer, FDA. The FDA was in no hurry. Senior policy officials wanted to move. The FDA wanted to do its usual slow, methodical thing. We had pushback from senior FDA scientists saying, we don't want to be rushed. We're going to resign. We protest. Well, this is in the middle of a pandemic. We're going to have a next wave, even if we don't know exactly when. and we need the population to be boosted before we get there. And we, in fact, had excellent, overwhelming evidence from Israel. But the FDA didn't want to believe Israel. They wanted their own data, but the US didn't have the data because they're not good at getting it. So there's a message here for me and a lesson for the next time about the need for regulators in the middle of a pandemic to figure out how to move faster than they might move at other times. Next slide. So 3 more letters, CDC. We didn't have the data infrastructure in the US to measure not much of anything. We couldn't measure vaccination rates. We couldn't measure remaining risk against hospitalization or mortality. We couldn't measure waning, especially not in real time. And we still don't, and it isn't being built. And for me, it's the CDC's job to build it and to plan ahead. Next slide. That's really it. And so for me, this is both a data message and a regulatory message. Boosters worked. Now, in hindsight, we learned, yeah, if you're under 50, you weren't going to die after the initial vaccination anyway. We didn't know that at the time. But we did know that boosters helped over age 60. We could have moved faster. Other countries did move faster. And we had a regulatory apparatus that got in the way and a data infrastructure apparatus that got in the way and still gets in the way because we're not building the data that we need to build. And so many of you remember these little white cards that show that you were vaccinated. I don't know what other developed country was using little white pieces of paper rather than an electronic registry of who was vaccinated. You know, astonishing unwillingness to collect data on a national level to figure out who was vaccinated, who died, and so on. And that is relevant for the next pandemic. We don't know what it'll be, but we know we're going to need data to figure out what to do about it. And we ought to be working on building the data infrastructure now so that we're ready when it happens. Thank you.
Thank you very much. And first off, I'd just like to say thank you to Health Affairs for the opportunity to present the findings of our paper for you all. And it's an absolute honor. Next slide, please. So we reviewed 50 papers that looked at COVID-19 misinformation interventions. In total, we looked at 119 interventions as papers. Some papers included different studies in which there were multiple interventions tested. So on the right side of this, you can see kind of the distribution of different intervention types that were found in kind of the evidence base. And already you start to see kind of its substantial heterogeneity in the number of different intervention types being tested. So for example, there are many more passive inoculation, debunk, user correction, and accuracy prompt interventions compared to media literacy and active inoculation interventions. Now, the aim of this review is twofold. It was not only to better understand what interventions were potentially most effective at mitigating the impacts of COVID-19 misinformation, but it was also to interrogate the methods used to consider what constituted an effective intervention. And by that, I mean, what forms of misinformation were interventions being tested against? Were they more innocuous claims like gargling salt water would cure you from COVID-19, or were they more harmful content like injecting bleach would cure you from COVID-19? And we wanted to understand as well the mediums through which misinformation was being presented to participants, such as were they presented through audio? Was it text-based only? Was it video formats? Or was it image and memes? Next slide, please. So because we identified a wide range of outcome measures, there were 47 in total that we identified. And to make the evidence a little bit more approachable for public health experts and practitioners, we grouped outcome measures into several distinct buckets. So we have beliefs and accuracy judgments, we have quality of content shared, we have manipulation discernment, and we have measures related to public health. And in a review, we found evidence of debunking interventions helping to improve participants' beliefs and accuracy judgments around COVID-19 misinformation. We found evidence supporting accuracy nudges as a way of improving the quality of content being shared by participants. And while we did find evidence supporting other interventions that improved both beliefs and the quality of content shared, there was comparatively less evidence supporting these interventions when compared to debunks and accuracy nudges. We also found evidence supporting active inoculation, and some people think of that as kind of gamified interventions as supporting and improving participants' ability to identify manipulation or manipulative content. And then we also found evidence supporting passive inoculation interventions as improving participants' intent to vaccinate. So kind of an important finding potentially for public health experts. However, and I cannot underline this, however, enough, while we would all like to have clean, tidy, and concise evidence pointing to one overarching intervention that solves the dilemma of misinformation forever, we don't live in such a fantasy world. And these findings come accompanied by other findings that complicate our ability to say decisively what interventions work the best against COVID-19 misinformation. Next slide, please. So as I mentioned before, there was substantial heterogeneity in the number of different intervention types tested. And not only do we identify a wide range of outcome measures, there were 47 in total, but we also discovered variation in the ways in which the same outcome measures were being evaluated, complicating attempts at comparing evidence and making sense of the evidence more holistically. Furthermore, only 18% of the interventions included public health related outcome measures like attitudes towards vaccines or intent to vaccinate or COVID behavior. There were a few interventions that were tested over the long term, which limit our ability to say whether the effects of these interventions last beyond the actual study. And how these interventions fare outside of the US remains relatively limited. And despite more and more people consuming video-based content, including misinformation on platforms such as TikTok and YouTube, only 4% of the interventions presented misinformation to participants in video-only formats. And furthermore, the kinds of misinformation varied quite considerably across the studies. So for example, conspiratorial content related to COVID-19 vaccines was presented to participants in only 9% of the interventions, despite conspiracy theories oftentimes being stickier and more resistant to correction than other forms of misinformation. Next slide, please. So based on these findings, we offer the following recommendations on how to advance research on misinformation interventions, specifically as it relates to the field of public health. Now, we need to include more public health experts, including local experts with context-rich knowledge in the development and implementation of interventions. We need to develop and agree on consistent outcome measures so as to make evidence more comparable. We need to test more diverse forms of misinformation, such as misinformation presented in video, audio, and meme-like formats instead of kind of text-only formats. And we need to acknowledge that misinformation is not a monolith. It can be explicit or implied. It can consist of different claims, framings, emotional valence. And the sources of misinformation vary widely as well. It can be a fellow social media user, or it can be the leader of a government. So we need to consider all these different facets of misinformation when developing a kind of more robust typology. Furthermore, we need to test interventions more internationally, and we need to invest in more research examining the impacts of interventions over the long term. Next slide, please. Now, if nothing else, what this review suggests is there is no silver bullet to COVID-19 misinformation. And ultimately, we need to be supporting research that looks at the impacts of community-driven interventions as vigorously and aggressively as we're doing with individual-level interventions. Thank you very much. And I will pass it on now to, I believe David is up next.
That's right. Thank you, Rory. I'm David Ridley. As the slides come up, I'll tell you about myself and my co-authors. My co-authors are Emily Cuddy, who's a professor of economics here at Duke, and Yun Peng Liu, who's a graduate student at Maryland. Like the other papers in the session, we focus on COVID-19 and the pharmaceutical industry. And like Professor Black, we will be critical of some of the staff of the FDA, whom we believe are not going abroad like they should. But we'll also talk about other mechanisms for ensuring quality. Next slide. So I will always be grateful to the team at Health Affairs for holding briefings like this. 17 years ago, I participated in a briefing. It was not on Zoom. Zoom was still 5 years away from being founded. It was at the National Press Club. But it was because of a Health Affairs briefing that our paper became law. So I presented our paper proposing the priority review voucher, and a reporter who's now a medical doctor named Laura Blinkhorn came up to me afterward and told me some senators that would be interested, and they did, and it became law the next year. So for me, at least, these briefings are potentially very high impact. I'm not expecting that this paper becomes law, but I am grateful for the reach that Health Affairs has. Next slide. And I've got animation in these slides, forgive me. Thank you, Ryan. So in our article, we look at FDA drug quality inspections. We ask, how far have inspections fallen? And the answer is very far. They fell quite a bit during COVID-19, as you would expect. But the concerning thing is that they have not recovered, especially for foreign inspections, and I'll talk about that. We also look at other things like how far pharmaceutical imports have fallen. They have not. And we suggest some steps for FDA, Congress, purchasers, and patients. So this is not just about the FDA. This is about many more of us. Next slide. We obtained data from the FDA through a Freedom of Information Act request. So for several years, we've been acquiring information from the FDA, and we use that in the study. We also use some less granular, more current data from the FDA dashboard. Next slide. This is Exhibit 1 from our article. We plotted FDA drug quality assurance inspections over time. These are stacked. So you've got countries stacked on top of each other. So the total there is all the inspections in that month added up. I think the most obvious thing that you can see in this figure is that inspections fell with COVID-19 and they haven't recovered. Okay, in the next slide, I want to zoom in on the United States. So here you see domestic inspections. Domestic inspections are down 35% in 2022 compared to 2019. And in the next slide, you see foreign inspections, and you see that those have not recovered at all. So you see we've broken this down. We used the FDA regions. These are where the manufacturers are located, not necessarily the FDA people responsible. But you see a massive decline with the start of COVID-19, as you'd expect. But what's surprising is it hasn't recovered. Okay, what about 2023? That's the next slide. So these are more recent data from the FDA dashboard. They're more aggregated, more macro. But what you can see is that 2023 looks a lot like 2022, when it should look much more like 2019. Next slide. Here you see the share of inspections that have official actions indicated. So official actions indicated, OAIs, are the most severe outcomes for an inspection. And you see that those rose after the start of the pandemic. This is not entirely surprising. We'd expect this rise for a couple of reasons. Number one, I hope the rise is driven by selection, and that is that the FDA is focusing its few inspections on the most problematic establishments. If you focus on the most problematic, most likely to have problems, they do turn out to have problems. But another possibility is that with the more time that passes between inspections, the more manufacturers get sloppy, the more manufacturers shirk. There's plenty of previous evidence that with longer lags between inspections, there are more problems when the inspectors finally show up. Next slide. So there are a variety of reasons why the non-emergency inspections stopped at the start of COVID-19. Although it's harder to explain why they were not picked up. So obviously travel restrictions mattered early on. However, Mexico largely reopened in 2020, at the end of 2020, and FDA inspectors did not go to Mexico until 2022. So travel restrictions are not all of the story here, especially not in 2022 and 2023. And there were no decline in establishments, there was no decline in production, there was no decline in FDA budget or overall staffing. So FDA still had the resources, but its staff were unwilling to travel. Next slide. So policy implications, I have 3 slides here, so or several slides here. The first is that the FDA is going to need to prioritize foreign inspections. There's this massive backlog that it needs to catch up on. And the FDA will need to hire more staff who are willing to go abroad. This is not trivial. Many of the staff are unionized. Many of the staff don't want to spend a couple of weeks away from family for each inspection. Many of the staff don't want to relocate to India and China. So the FDA has offices in India and China, but they're perennially understaffed. It's hard to persuade staff to move, and that's understandable. As I understand it, part of the reorganization being led by Dr. Janet Woodcock it's manyfold. Part of it is having different people in charge of the inspections, but part of it is also hiring staff who are willing to travel, perhaps who even find it appealing to early in their careers get some international experience. Finally, it'll be important for the FDA to continue to leverage other resources. The FDA has conducted very few formal virtual inspections. Needs to do more, but not as a replacement for in-person, still needs the in-person as a complement. Also, mutual recognition agreements with Europe have been useful. Next slide. But the responsibility should extend beyond the Food and Drug Administration. So buyers should share in the drug quality burden. I mentioned here Kaiser Permanente and the Department of Defense. Both of them are not taking for granted that generic drugs are safe and effective. They are hiring outside labs to test drugs, test some of the most popular drugs, and then they are choosing the generic drug manufacturers who have the best outcomes in those trials. So they hire, for example, Valisure, who test their drugs. If some manufacturers perform especially well, then they say, aha, going forward, we will focus on these manufacturers. I don't have this on the slide, but this morning I watched the Senate Finance Committee briefing on drug shortages. And a vice president from Civica RX said, we focus on US manufacturers. And we can see from this that there's some reason for that, because FDA is also focusing on US manufacturers. So, you know, at least some of them are being inspected. But also we pay attention to who makes the drugs that we provide to the hospitals within our network. So Civica RX is thinking very carefully about which drugs it supplies to hospitals. That Senate Finance Committee was all about preventing shortages. They're choosing reliable manufacturers to avoid shortages, but they're also thinking carefully about the quality of the drugs. We need more players like Civica RX, Department of Defense, Kaiser Permanente, not just assuming that FDA is going to do the full job, because they're not, but taking some responsibility for the quality of the products that are in the supply chain. One thing that would help more players pay attention to this would be if patients paid attention to this. So if patients knew that the FDA has inspected very few foreign establishments over the past few years, and that those foreign inspections are not surprise inspections. The FDA gives several weeks advance notice of an inspection. There have been a few exceptions. There was an experiment in India where they didn't give advance warning, but for the most part, 99% of these are given advance warning. American people should be aware of this and should think carefully about which generic manufacturers they're selecting. It'll be a hard shift for us, but it's certainly possible. When I talk about this in class, many of my domestic students say, yeah, I don't pay any attention to the label. And many of my international students say, of course I pay attention to who makes my drugs. So I think in some respects, we in the United States, or Americans, can be outliers in this and would be well served by paying more attention. Next slide, please. I showed you essentially 2 of our exhibits. There are 2 more exhibits in the paper. including one that's interactive. There are 9 more exhibits in the appendix. So thanks to those Freedom of Information Act requests, we've got a lot of data to share with you if you're interested. Next slide, please. So the FDA is doing incredibly important work. There's some wonderful public servants of the FDA. So I do feel awkward about picking on this in this regard, but some of them are not going abroad and need to go abroad, and the rest of us need to take more responsibility for drug quality. Next slide. So thanks for you. Thanks to you. Thanks to Health Affairs for this opportunity, and back to you, Corrina.
Thank you so much. Thanks to all of our speakers. That was a really exciting panel. I'm excited to move into discussion, question and answer. I'll sort of field questions to certain people, but if others also would like to contribute, please feel free. I had a question directed towards both Peter and Rory. I think your presentations together really highlight the urgency of addressing vaccine hesitancy and misinformation. Of course, you don't have a crystal ball, but I'm curious both of your sort of opinions about the hopes for slowing or reversing the trends that we've been seeing. And, you know, on a sort of optimistic note, what role might policy and policymakers have to play in addressing these issues?
Who do you want to go first?
Peter, go ahead.
Okay. Well, thanks. I think it's a two-pronged approach. I think, and it's one, improving the quality of health and science communication, but I think the bigger piece is combating the actors who are really creating a very predatory anti-vaccine movement. I think one of the things that concerns me is there's this kind of revisionist history going on that wants to blame the Health and Human Services Agency, saying they screwed up communication. That's why there's vaccine hesitancy, and that's false. Yes, there were things that could be improved, no question about it. But we have to identify the major source of this, which was a well-financed, politically motivated, predatory anti-vaccine movement that came out of the highest levels of the U.S. Congress, the House Freedom Caucus, some U.S. senators, and then this was documented both by Media Matters, a watchdog group, and a research group out of the Federal University of Science and Technology in Switzerland, ETH Zurich, amplified every night on Sean Hannity, Laura Ingraham, and Tucker Carlson, that during that Delta wave, when vaccines were widely available, filled their broadcasts with anti-vaccine content. And the point is, it's not some theoretical or academic discussion. It killed 200,000 Americans who refused COVID vaccines. They were victims of this predatory movement, overwhelmingly in red states, and the redder the county, the lower the immunization rate and higher the death rate. Hence, David Leonhardt of the New York Times just simply called it red COVID. This came out of research done by 3 groups, Charles Gaba, the health analyst, and among others. Same with Kaiser Family Foundation. So how do you go up against that? It's the health sector is fumbling at that one because the health sector doesn't know what to do. And so what you see is kind of skirting around the edges, switching up computer algorithms on social media, and enhancing our health communication. All those things are good things to do, but they're going to get us 30 to 40% of the way there unless we do something about the predation. In my opinion, in terms of improving health communication, Operation Warp Speed allowed the pharma companies to communicate untethered, right? And what Moderna and Pfizer did, they sent out their press releases that do what press releases do. They're not meant for you or for me. They're meant for their shareholders to jack up their stock prices. And they wanted to spectacularize their accomplishment of mRNA vaccines, making it sound like they appeared out of nowhere. They didn't. They appeared out of 15, 20 years of research that we did on the spike protein, that the Penn group did on mRNA. But by spectacularizing their accomplishment, it was tone deaf to the fact that it was frightening for the American people. And many said, well, how could these vaccines be legit? So one of the mistakes for Operation Warp Speed was not putting any constraints on how the pharma companies communicated to the public. Then, there were things that CDC and the other agencies could have done better communicating. They tended to use an old school way of communicating that says you have to talk to the American people like they're in the 4th grade or the 6th grade. I found that wasn't true. I found that unless you were full down the Joe Rogan and Fox News rabbit hole, that you were willing to tolerate a very high level of complexity, and I found that was more successful. So we do have to shift. We do have to provide instruction, ways to provide opportunities for medical students, PhD students, postdocs, residents to learn how to do health and science communication. We have to do something about offices of public communication and academic health centers that too often are in conflict with this. They want to do everything to keep the institution out of the headlines and discourage health communication among their docs and faculty. So that has to be done as well. But it's just a huge amount of work to do. So I'll stop there.
And I'll just speak briefly on from the intervention side. So I think ultimately we know that different initiatives are endowed a little bit differently, and I think it's a resource issue right now. I think everyone does really want an intervention that works for everything, and we have to acknowledge that that's never going to happen. And I'm a bit worried that most of the funding goes to individual level interventions as opposed to lots and lots of the really, really good community-centric interventions that are happening specifically in the most at-risk communities, such as Latinx and Hispanic communities and Black communities. And it's interesting as well that all of this happens in a local journalist vacuum, right? That's why people are overly relying on news streams such as Fox and Newsmax. And unfortunately, it comes down to where there's news deserts, oftentimes bad ideas seem to percolate in these communities. So I would, again, I think funding needs to be oriented not only at individual level interventions, because there are a host of really, really talented researchers doing phenomenal work. And again, I think we have to acknowledge that this field still is very young. It's still very much in its nascent stage. But that, funding needs to be prioritized both for individual level as well as the tons of good local journalist initiatives and other interventions that are happening at the community level. And I think, honestly, we're currently doing interviews with stakeholder audiences, primarily researchers, journalists, and practitioners. And what we seem to hear a lot of is that we also need to develop frameworks for evaluating these community interventions, right? So that we can provide evidence of their robustness and helpfulness in a way that these experiments done in lab settings are able to do, right? So whether that's through observational studies or whatever, but they definitely need help in terms of developing these evaluative frameworks. And I think that's also really important. We can't forget about that.
Great, thank you. I have a question for Bernard and David, especially given some of these comments about the importance of communicating during emergencies, the type of communication, the communicator. In both of your presentations, you talked about potentially sensitive policy decisions to be made and communicated. So in the case of Bernard, making decisions about when to roll out boosters in terms of timing of evidence. In David's case, how to communicate about drug quality from a regulatory perspective. And you can imagine that both of those are particularly challenging to communicate about on the backdrop of both an emergency, but also misinformation and anti-science sentiments. And so I'd love to hear both of your perspectives about if you have any thoughts on sort of how policy communication and policymakers might want to adjust the way that they message, should they adjust in this sort of backdrop of misinformation and the importance of communication that's come up several times on this panel.
So let me start maybe by seconding what Dr. Hotez said, which is the population isn't as dumb as the CDC acts as if it is. And we came out with a super simplified message. Vaccines are wonderful, don't worry, right? And then in 6 months, they weren't so wonderful. And we had to say, oh, gee, maybe they aren't so wonderful. Maybe you need a booster, as opposed to saying up front, they're wonderful right now. And in 6 months, we'll see. And we also saw one of the pushbacks for boosters was, don't tell people they need a booster because we're going to discourage other people from getting their first vaccine. And I remember being there in 2021 and thinking, this is just nuts. You are killing people who need a booster by not letting them have it and not telling them they need it, because you hope that if you don't tell them they need it, other people will get an initial vaccine. We need a way to have a more differentiated message that says, you know, the need for vaccine really is very different for different populations. We still don't have that today, right? We still have the message of everybody should get the latest booster. And I don't even know if that's right under some age. I don't know if it matters. We don't have good data. It may matter for the elderly. Do we know that a fifth shot matters versus a fourth? We don't. Probably not a bad idea, but it's not like we actually know. But under some age, whether it's 40 or 45 or 50, if you've gotten 2 doses, and certainly if you've got 3, they're going to keep you out of the hospital unless you have severe comorbidities. And maybe you want to get another one, but you're just not in the same category as somebody who's 75. And we don't have that nuanced message. I don't know if I would recommend an mRNA vaccine to a 20-year-old man. There's not much of a risk of myocarditis, but there's also not much of a risk of COVID. And we don't have the ability to send that more nuanced message.
It's a fabulous question, Corrina, and I agree with Professor Black. I agree with the value of nuance and communication, although it's hard. I understand why some government officials would worry about nuance, but I'm with Professor Black that we need that nuance. For our paper, the question is whether the FDA should acknowledge that not all generics are equally good. I think, and acknowledge that they're not inspecting every establishment. It could create panic. It could push people toward very expensive branded drugs. What I hope is that it will make them discern between generic drugs, that we Americans might be willing to pay a few extra cents to a manufacturer that has demonstrated high quality. I'm concerned that price competition is so fierce in the United States and US generics that it's a race to the bottom and nobody's paying attention to quality. And if we tell everyone quality is always good no matter what, then I think that's a problem. So I would like to see more nuance and more responsibility for purchasers.
Let me offer one more piece of nuance, right? All vaccines are not the same, even though we pretended they were, okay? So it turns out, we didn't know this at the time, that the remaining mortality risk for the first 2 doses from Pfizer through mid-2022 was about 2.5 times Moderna. CDC never told us that. The CDC's own studies suppressed the differences between vaccines and just reported average results for all mRNA vaccines. Did they not look? Did they not see? I mean, these are big differences that we were never told about. Now, why we have those differences, I can speculate that older people need the bigger kick that they got from Moderna. And our evidence also says once you get the 3rd dose, the differences shrink to statistical insignificance. But even today, there's a real lack of understanding that not all vaccines are not the same. And I won't even go into Johnson & Johnson because we kind of know that that's worse.
Well, I think, you know, one of the amongst the problems was at least early on, the CDC's gotten better since, but early on they weren't measuring or publishing any kind of vaccine effectiveness data. So we were depending on Israel and the UK for all of our vaccine effectiveness data. And they had Pfizer. They didn't have J&J. They didn't have Moderna. So, you know, if you got Pfizer, if you got the Moderna, you'd look at their Pfizer data and kind of try to extrapolate to Moderna, assuming it was similar. In some cases, yes, some cases, no. And if you got the J&J vaccine, you had buyer's remorse because, hey, nobody was publishing any data on J&J, and that was a problem also. The other thing that happened was, you know, the vaccines were approved on the basis of effects on symptomatic infection, symptomatic illness. but then what happened was the Israelis provided data in early 2021 that the vaccines were also interfering with asymptomatic infection and actually halting transmission as well. And that was very exciting. And that's when the decision to take the masks off came about. But then what happened was, with the change in the virus and the Delta wave, the levels of virus neutralizing antibody went down, and you weren't getting that same level of interfering with infection and transmission anymore. And then the masks had to come back on. But the point is, it wasn't really explained to the American people the basis for it. So there was never that kind of underlying assumptions presented. And you're right, when the vaccines rolled out, 2 doses and you're done. Well, no, I mean, we know from vaccines, pediatric vaccines, that what you do is you give a series of primary immunizations, you wait 6 months to and then you boost. And so what I was saying is, well, I don't know if it's going to be 1 and done or 2 and done. It might be 3 and done because of the boost. And during the Delta wave, I was looking pretty good. But because then you needed that boost. The problem was, it turned out that the length of protection waned pretty quickly in these mRNA vaccines after 6 to 8 months, but that wasn't explained. So there was this, insistence on simplistic messages. And I think in what the CDC wanted to do was give one message for the American people. And unfortunately, we had 2 countries, one that was all in and wanted to do whatever it took to protect their health of themselves and their families. The others were all out and they weren't listening anyway. And so they amortized it with a single message that came out like baby talk. And I think that wound up backfiring.
We had the same problem with masks, right? We got the message, wear a mask. We didn't get the message, wear a respirator mask, as opposed to wear any mask. We got the message, wear any mask. And we knew better, right? We knew there was a difference between a properly fitted respirator mask, the N95 or the KN94, and the flimsy surgical masks that were sitting in lobbies all around.
Right. But I think, the point though is to say, yes, there were clear flubs in communication. My other point though was, even if the communication had been perfect, we'd still be in a similar situation, because the lion's share of what went on was a very aggressive, politically organized, anti-vaccine, anti-science movement that operated at the highest levels of the U.S. Congress. And by the way, it's not ending. I mean, now that the accusation's out there, the 200,000 Americans needlessly died, we're seeing this kind of revisionist history in place now, in which it's playing out in the House subcommittee hearings. I mean, on their official Twitter site, they even say they're selling popcorn, quote unquote. I mean, that's how awful it is. It's pure political theater. And they're basically trying to say, no, it was the vaccines that killed Americans, which is absolute nonsense, or that the scientists created the virus, which is absolute nonsense. This is revisionist history, and it's so damaging to our country, and it's putting so damaging to our biomedical scientific infrastructure. It's going to take us a long time to recover from what's going on right now.
I just want to bring this back momentarily to because we are talking about low and middle income countries in this special issue, and to bring this line of conversation back to low and middle income countries, it strikes me that the difference between the effectiveness of mRNA vaccines is like quite literally a first world problem, because a lot of the low and middle income countries, as our research showed, didn't even have access to mRNA vaccines. And so, our research can't tease this out, but I do think that it's an important question. How much of people's low uptake, especially where supply was more limited, was due to actually waiting for the more effective vaccines to maybe become available. In many low and middle income countries, the first vaccines that were available were the Russian vaccines or the Chinese vaccines, a lot of that driven by sort of vaccine diplomacy, those countries trying to get out ahead of the West, and the very slow delivery of COVAX, not really supplying adequate quantities in the right time frame for many low and middle income countries. So, just want to kind of bring this conversation back to that. And so I think there were people who were, waiting for better vaccines to become available in low and middle income countries. And, there wasn't clear if you got the Chinese vaccine, would you then be eligible if J&J came along? And for many countries, actually, the J&J was a very good option that a lot of people were waiting for. So I just wanted to bring that into the conversation.
Thank you. And this has been a great conversation. I'm very sorry to have to end it, but I know we have a third panel that we need to get to. So I just wanted to thank all of our panelists for your work on the issue, your presentation today, your engagement in the discussion. Thank you to the audience members, and back over to you, Alan.